Good evening and thank you everyone for joining us today. I am Amit Saxena along with my teammates from Jagsonpal Pharmaceuticals Ltd, Dr. Deepika Chavda and Mr. Arvind Singh from Medical Services, and from NAARI Division of Jagsonpal, Mr. Mukesh Awasthi, GM Sales and Marketing, Mr. Subrata Dhar, AGM Sales, Mr. Saurav Sharma, Marketing Manager, and Mr. Vijay Singh, Brand Manager, Yuliprist. I'm delighted to welcome you all today to this important session of fibroids management and re-entry of Ulipristal Acetate in Indian scenario by experts from across India. Today's discussions are brought to you by NAARI Division of Jagsonpal Pharmaceuticals Ltd, makers of Yuliprist 5 mg tablets, helps you save her uterus. A warm and hearty welcome to esteemed experts and attendees. Dear attendees, we request you to post your questions and suggestions or clarification by text in Q&A box. Please note this webinar is streaming live on Facebook and the link has already been shared on the chat box. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. As we initiate the session today, we would take a minute to salute the Indian woman and then request Dr. Deepika Chavda, GM, Medical Services, Jagsonpal, to kindly initiate the program.
Yatra naryastu pujyante ramante tatra devata is a Sanskrit verse meaning that God resides in a place only where women are respected, and India is striving to be one such country. Despite the discrimination women face, they still come out and excel in various fields, proving their ability each day. The position of women in Indian society has improved to a far extent, and we still try to make it up to the best. The role a woman plays in everyone's life is not a piece of cake. From taking care of her family, fulfilling their needs, and her responsibilities in the society, a woman needs patience, talent, endurance, and whatnot. And we therefore dream of an India where women are treated as its assets and not its liabilities. We salute to all such women.
Good evening, dear faculty and attendees. We take this opportunity to thank every one of you for your interest in Yuliprist 5 mg tablets of Ulipristal Acetate and for joining in today in large numbers. We begin the session today with the introductions of the facilitator of the discussions and the experts. We shall go as north, east, west, south for the introductions, not in alphabetical order. So we introduce and welcome Dr. T. Ramani Devi, Janani Trichy Fertility Center. She's past chairperson of Endometriosis Committee FOGSI. And during her tenure, she brought out the FOGSI GCPR on endometriosis, which we were very fortunate to be a part of. She has held many office positions, including Vice President FOGSI in 2020. She shall be facilitating the discussions today. Welcome and thank you very much, ma'am. The expert commentators today are from across India. We thank each one of the experts for your time and commitment to the cause of women's health. Dr. Sonia Malik, Nova, Dr. Sonia Malik, Nova, Southend Fertility and IVF in Delhi. She has held office of the President, Indian Fertility Society and Chair, Infertility Committee FOGSI, among others. Welcome to you, ma'am. Dr. Basab Mukherjee from Calcutta. Dr. Basab holds prestigious office positions as Vice President for FOGSI and for Bengal Obs and Gynae Society, RCOG India Representative East Zone, and has been ICOG Governing Council member. Your inputs are valuable. Welcome, sir. Dr. Archana Basir, Akash Hospital, Indore. Dr. Archana Basir, she is SAFOG Chairperson, Imaging Science Committee, and RCOG India Representative West Zone, besides Vice President FOGSI in 2020, and holds the Guinness World Record for largest uterine tumor removal. Welcome to the discussions, ma'am. From Coimbatore, expert Dr. Asha Rao joins us. She is the Director, Rao Hospital and Care, Coimbatore. Ma'am is the current Chairperson, Endometriosis Committee, FOGSI, and past President, Coimbatore Obs Gynae Society, besides taking postdoctoral fellowship programs affiliated to Tamil Nadu, Dr. MGR Medical University, Chennai, in reproductive medicine and endogyne as director. Welcome to you, ma'am. Now, with the introductions being over, we hand over the platform to Dr. Ramani Devi, ma'am, to kindly initiate the academic session, ma'am. Thank you.
Thank you, Dr. Deepika and the entire team of Jagsonpal for having given us this. It was her, I think, long drawn wish for Dr. Deepika to introduce something about the re-entry of Ulipristal Acetate in the Indian scenario. And ultimately, we have got today with me excellent panelists from all over the 4 zones, and the senior most person, Dr. Sonia Malik, whom I respect the most, and my dear friends, Dr. Asha Rao and Dr. Archana Basir and Dr. Basab Mukherjee, for this panel discussion on what is the current role of Ulipristal Acetate in the Indian scenario. So let me put it as a panel discussion, and I'll be putting on certain questions for which each panelist will be giving their expert opinion. And ultimately, we can form a sort of consensus about the use of Ulipristal in Indian scenario. So the flow of my presentation will be something about epidemiology, pathophysiology, symptoms, limitations of the current drugs available and its use, and Ulipristal, the clinical pharmacology, and what are the indications for the use of Ulipristal for fibroids, and some discussion about the Pearl studies, clinical evidence for re-entry of Ulipristal acetate, and summary. So the first thing is uterine fibroids are the commonest benign tumors that are found among the women, and it forms the frequent indication for women to undergo hysterectomy in almost 30% of the patients who are undergoing hysterectomy. And in African American, the incidence is quite high, and almost 60% of the women with the age of 35 years and 80% beyond the age of 50, they suffer from fibroids. And among the Caucasians, it is around 40% by the age of 35 and 70% by the age of 50. So that means it is the most common benign gynecological condition that is being found among the women. So approximately in India also about 15 to 20 million women suffer from fibroids. So they are very often very solid pelvic tumors and most frequently reported indication for major surgery in premenopausal women. So let me put this option of first question number 1 to what is the prevalence of fibroids in their own zones? Starting with Dr. Sonia Malik. Though she is a fertility consultant, I think she can give her insight regarding the incidence of fibroids, what she comes across among infertile women.
First of all, thank you very much for having me here on this panel, Dr. Ramani and Deepika. Thank you so much for this exceptionally different panel and different subjects. Thank you so much for making me a part of this. Fibroids, I think they are the most common tumors, even in the infertility segment. on an average, we are seeing about 2 to 3 patients of fibroids in our day-to-day practice. So they may not be symptomatic, but they are there. So patient may not come complaining of anything like that, but when you're examining them, you do find that the patient has fibroids. So I think it is a very, very common tumor. I won't be able to tell you the exact prevalence in the infertility segment, but the Government of India on the Ministry of Health website, if you go, you find that it is stated that about 15 to 25 million patients of fibroids are present at any given time in India. So that makes it a very, very common tumor in India. Very common. The prevalence.
Thank you, madam, for your input. Dr. Archana, what is your experience?
Thank you very much, Dr. Ramani, for including me in this very interesting panel. Thanks to Jagsonpal and Dr. Ramani. I think, when you talk about the incidence or prevalence of uterine fibroids, they are, as Dr. Sonia Malik has already said, they are one of the most common tumors in the women. But when you talk about the exact incidence, we may not be able to tell because many are asymptomatic. So we don't know, what is the actual incidence. But if you take by and large, it is between 4.5% to 68% is the incidence of the prevalence of the fibroid. And it is more in the infertility group because like if you're running an infertility setup or if you're doing a specialized endoscopy setup, then you find the more number of women coming to you with the fibroids. And then we are right now in India, so we don't talk about, but like I worked in the UK and where we were used to find they're more common in the Black women than in the Caucasian women. So the racial factors also impacts the prevalence and incidence of fibroids. But overall, between 4 to 68% is the prevalence of fibroids in population.
Thank you, Dr. Archana. Dr. Asha, can you share your experience of fibroids in infertility as well as in the general population?
Yeah, fibroids are very amazing conditions. On one side, it can be totally silent. It is very interesting to see a woman with 15 fibroids conceives, and she would have had 2-3 children also and no symptoms at all. And a young girl married 6 months came to us with a huge fibroid and an early pregnancy. And on the other side, there are girls with tiny fibroids and so much of pain. I mean,
Dr. Asha, I think your
yeah,
network
difficulty
is-
in conceiving, so I tackle them.
Okay. So in general, among the general population, I think the incidence of fibroids probably because of the population also it seems to be increasing, and especially in infertile population because the women, they come at the beyond 35 years for fertility treatment. So we do get a lot of fibroids. So the prevalence is, according to the literature evidence, it affects 35 to 77% of the reproductive age group women and present in 5 to 10% of the infertile patients and may be the sole cause of infertility in 1 to 2.4%. And the incidence ranges up to 30 to 70% in premenopausal women. So the probable etiology is mainly because of hyperestrogenic status. And there is definitely some association with obesity, which indirectly increases the estrogen level. And of course, the genetics plays. That is why we get more and more of fibroids in the Black population. Now, what are the probable types of fibroids and what are the common symptoms? Again, anyway, anybody can start.
Asha can start.
Yeah. The common symptoms are menorrhagia, metrorrhagia. There can be miscarriages, sometimes dysmenorrhea, not always. There can be pressure effects. There can be retention of urine. Yeah, and then iron deficiency anemia. Even this can. So these are the sometimes preterm labor. I said reproductive dysfunction. All in one line.
So,
There's from infertility to miscarriage to preterm labor to retained placenta, PPH. All this sort of obstetric problems can also happen because of
reproductive problems as well as obstetric problems, starting from recurrent abortion two, I mean, like how you said it is PPH, anything can happen. And it all symptoms all depends upon the types of fibroids, isn't it? Yeah.
And some of them are asymptomatic totally.
Yes.
Which is amazing.
Subserous fibroids in general, they are asymptomatic because like how you said that it is even in early pregnancy, we can see a huge fibroid. I had the experience of operating a 3.6 kg fibroid in an early pregnancy of 12 weeks, which was totally asymptomatic. But at the same time, a small fibroid that is 2 centimeters, which is submucous, can cause lot of symptoms starting from dysmenorrhea and menorrhagia. So it all depends upon the site. So these are all the common types we understand, but the symptoms are, it can start from dysmenorrhea, metrorrhagia, menorrhagia. I think all these things have been mentioned by Dr. Asha. So then I would like to go, what are the common investigations we would like to do to confirm the site of the fibroids? Dr. Archana?
I think, Ramani, this is very, very important question. How really you diagnose the uterine fibroids? I think, but clinically it is too late, because unless it is too huge and you can feel per abdomen or you do the per vaginal examination. Now we have a very beautiful modality, that is ultrasound, which is quite, it can easily be learned, and you can pick up fibroid by ultrasound. Like you can clearly see the capsule of the fibroid. And you can actually type also by ultrasound what type of like you can do the FIGO classification of uterine fibroids, the type of uterine fibroids, whether it is intramural, submucous or subserous fibroid, or it is a broad ligament fibroid. And it can be really in a clinical practice, in a day-to-day practice, you can pick up by ultrasound uterine fibroids. And then, I mean, of course, if you have a very big fibroids or increased vascularity, you can offer patient MRI or like CT imaging. Saline hysterography was also mentioned for in the past about the submucous fibroids, which can still be practiced, and some people are still practicing. But with the availability of a good ultrasound with the high resolution and silhouette, and I think you can diagnose it by a good ultrasonography, 3D and 4D ultrasonography, you can pick up uterine fibroids. And of course, if you are doing any procedure like endoscopy, you can pick up by laparoscopy and hysteroscopy as well. But I would put a lot of emphasis on good ultrasound, because you have to differentiate it from adenomyosis as well.
Yeah, that is the point I wanted to bring about, because most often, many of the patients who are referred for myomectomy, laparoscopic myomectomy, when we do a proper 3D imaging or a routine ultrasonography, we find it is only an adenomyosis. I think in such situations, we have to depend upon MRI for a better imaging, as well as when you want to plan for laparoscopic myomectomy, I think myoma mapping by MRI is going to give a better input rather than simple ultrasonography, provided it is being done by a very good sonologist. So now
one more thing I can add here, Dr. Ramani. I mean, for a common gynecologist, if you talk about, like, MRI is not that affording thing unless you're planning to operate for fibroid or patient has presented with adenomyosis. Ultrasound, I mean, you should know the features, how to differentiate adenomyosis and fibroid. So it's one very important thing is when you put the color, and if it is at the periphery, it is a fibroid, and if it makes it like, all around, a myometrium, and then it is an adenomyotic nodule. So before the point which you are bringing here is that MRI does the mapping better, is very good. But when you are like operating, it is very, very important that whether you are operating a myoma or adenomyosis, because adenomyosis is difficult to remove and not a very common, means a routine gynec, while myomectomy can be performed a little with a ease by routine laparoscopic surgery, while adenomyosis becomes little tricky at times.
Yeah, you're right, Archana. 3D ultrasound is very, very good. But the problem is a normal gynecologist does not want to sit down and do a 3D unless they have a dedicated sonologist. So they feel that referring off for MRI is easy because the patient pays and we enjoy the benefits. Otherwise, I think a well done 3D ultrasound is
more than
Very
enough.
useful
I would
and-
say.
You know, if there are multiple fibroids all over the place, then maybe, you know, you have to locate the ureter and you have to see what are the
Yes.
pressure effects and all. Then in that case, MRI is more useful.
Yeah, all said in an
Of course.
MRI is accurate,
Of course.
except for the cost.
But of
Yes.
course, the cost, and of course, like Archana is saying very well, ultrasound is the extended arm of the gynecologist. After all, we, instead of doing a per vaginum examination, we are doing ultrasounds now. And it is very easy to diagnose fibroids on ultrasound. So that way, yes, she's absolutely right. We have to depend more on ultrasound, but like there are situations where you cannot do without an MRI also. It has its own place.
Yeah,
Yeah.
it's rightly you have pointed out that multiple myomas,
Yeah.
planning for myomectomy, I think this will be the ideal one. So can anyone tell us FIGO's classification of leiomyoma and what is its significance?
Mm.
That's now FIGO has come out with a newer classification of leiomyoma. I
Yeah.
won't say newer, it is for quite some time it is being in practice. And what is the implication? Whether it has got anything to do with the clinical management?
So it, as you are showing in this figure, it is very well described by FIGO that there are these different types of myomas, and they have given a grading 0, 1, 2, 3, 3 for the types that we have. We have the submucous, which is peduncle. 0 is intracavity, as you can see in the diagram very well. And then you have with 50% intramural and less than 50%, depending upon how much is the invasion into the cavity, how much of it is submucous. Similarly, when you have the others, which are basically either completely in the intramural region or 50% or less than 50%, depending on that, you have a number over here or a grading over here, which tells you what is exactly the location and the type of myoma. So it describes the type and the location and of course the size. So therefore, then you have these hybrid leiomyomas, which are also into the cavity and going outside, maybe into the intramural compartment or subserosal. So then they are graded as a number between 2-2-5, 2-5, which means that some amount is submucous and some amount is subserosal. So each myoma has to be dealt with separately, has its own implications in the sense of symptoms and signs and symptoms. And of course, the management also varies, because if it is a completely submucous, we are going to take it out hysteroscopically. But if it is all subserosal, then it is laparoscopic method. So therefore, this classification is very, very useful for all of us. And it actually should form the basis of diagnosis for all gynecologists when they are trying to treat myomas.
Yes, madam, 100% you're correct. So pedunculated and the myomas which are greater than 50%, I mean, less than 50%, like 0 and 1, they can be dealt very easily with a hysteroscopy. But the rest of the things, I think we need to go for a laparoscopy, and invariably the entire subserous myoma may not give you any problem unless it is very huge. So this is again ESG, that is ESG and FIGO together. They have divided into type 0, type 1 and type 2. Type 0 is totally submucous, and with that type 1 is greater than 50%. See that part of the submucosal myoma also they have brought it into intramural, and then the other things are the same. So this is a different, just a slight modification of FIGO. ESG has brought out this. So these are the currently two systems to classify submucous myomas, both by ESGE and FIGO. So now coming next to the pathophysiology of fibroids, do you think that pathophysiology of fibroids are important?
I think it is important because when you talk in terms of the treatment, once you know the pathophysiology, then it becomes easy to treat, because if you know the antidote, then it becomes easily treatable. So when you talk about the pathophysiology, what we know is that estrogen induced production of progesterone receptor, that PR receptors, and that is essential for response of fibroid tissue to progesterone. And progesterone actually causes tumor growth. It increases cell proliferation and survivor, enhancing extracellular matrix formation. So, I mean, basically, it is very, very important that one should know what is the pathophysiology of the fibroids. It will help you in management.
Yeah, so the hormonal management of fibroids are basically dependent upon the pathophysiology.
Yeah, because for a long time we blame estrogen for
Yes.
everything. But today we know that it's a progesterone which plays a
Progesterone
very,
that is
very
the culprit.
important role.
Mm.
And that's the importance of the sperms.
So what is the role of progesterone in leiomyoma pathogenesis? I think Dr. Archana had mentioned it. It increases like volume maintenance, growth of fibroids. They are progesterone dependent. And again, ovarian progesterone acts via PR to regulate the transcription of key genes for apoptosis, proliferation, and extracellular matrix formation. So progesterone has got a dual action that stimulates the growth by upregulating the epidermal growth factor, BCL2 gene, as well as inhibits the growth by downregulating insulin-like growth factor expression. So now, how do you in general manage fibroids in your current practice? A question to Sonia Malik, madam, how do you manage fibroids in your clinical practice?
So again, Dr. Ramani, the management of this condition will depend upon what we are dealing with. Number one, there are multiple factors. Number one, the age of the patient. Number two, the type of fibroid. The symptoms of the patient, the signs of that we have found on examination, and then the site of the fibroid, the size of the fibroid, all that is going to determine, and the complaints that she's actually coming from. So all that is going to decide how we are going to manage this patient. If she is very symptomatic, if she has a lot of, say, menorrhagia, metrorrhagia, dysmenorrhea, and all that, and even though the fibroid is small, we still have to do something about it because she's in terrible situation. If she is asymptomatic and the fibroid is in a situation, say it is intramural, and it is not a big fibroid, we may not do anything about it. So every fibroid is when we talk of individualization of treatment, I think it extends to every condition in gynae and obstetrics. Everything is individualized, and so also the management of fibroids. Every fibroid has to be managed individually. And of course, we have various forms of treatment. We can manage them with medication, we can manage them surgically, depending on what it is.
Okay, Dr. Asha, suppose if it is going to be a submucous myoma causing lot of dysmenorrhea and menorrhagia, what is your way of treatment? Are you going to manage it medically or surgically?
Yeah, this is a symptomatic fibroid, number one. Then you have to consider what is the need of the patient. Is she a Paris woman or is she a young woman wanting fertility? But if it's causing a lot of symptoms and it's grade 0, definitely we'll go in for a hysteroscopy and remove it, because there's no point in subjecting them to medication for a long time. So whichever is surgically correctable, easily removable, I think it's wiser to manage it through hysteroscopy. But if it is partly intramural, and which is not in need of pregnancy, then I would definitely think more in terms of medical management.
Can I put up one question here to the panelists just to make it a little, just now I came from my OPD, I had 35-year-old women. I did her C-section 7 years back. Her hemoglobin is 7.6 gram and she has 4 centimeter fibroid. She is non-desirous of pregnancy now, but would you do a myomectomy or would you offer a medical treatment?
You just
4 centimeters, she is
4 centimeters. She has a short cycle, 20 to 25 days. Her hemoglobin is 7.6 and she has 1 C-section, but she doesn't want any more pregnancy. And she's only 35 years.
Where is the fibroid? Where is the fibroid?
Fibroid is intramural fibroid. It is intramural fibroid and it is at the fundus, 4 centimeter.
Yeah, I think this patient, first of all, she is symptomatic to the extent that she has got anemia, severe anemia. So she needs to be treated somehow. If she is not keen on a baby, I think I will put her on a medical management, because surgery is not warranted for an intramural myoma. It is not jetting into the cavity. Probably this sort of people will be helped by medical management. This is my view. This is how I would like to treat my patient.
Same thing I did, because I said once your hemoglobin is also low, 7.6, and she's like just the short cycle, menorrhagia only for 2 days. So I think you're right, Dr. Ramani, medical management will be the first choice, because we are trying to save uterus these days and trying to save the surgery if we really can be helped by the medicine, and if we have good medicine available.
Yeah, let me put up one question. Tell me, madam, go ahead.
Sorry, after you.
Yeah, no, suppose if the patient is very keen, would you like to subject her for uterine artery embolization or MRGF IFO, MRGFUS?
Well, I mean, patient, suppose if she's keen on, you saying fertility, right? What did you say?
Yes.
No.
See, instead of surgery or medical therapy, would you like to go for a non-surgical alternative like UAE or MRGFUS?
Well, if Dr. Sonia is answering, what my take on this is, Dr. Ramani, it is not that widely available. The treatment we are talking about, uterine artery embolization and magnetic resonance thing, they are available at the fingertip places. And another, I had a couple of times I had sent my patients for uterine artery embolization. It is again one of the expensive treatment available. And then there are other problems associated with this, like, when you are doing uterine artery embolization, patients sometimes have intractable pain in their legs and all. So I think these remedies are good, but they should be kept for a very selected group or a subgroup of women. You cannot offer it to all.
Yeah, this is the message I wanted to disseminate for the viewers. Sonia, madam, now you can go ahead with your...
I was saying that I would still want to sample the endometrium before I put her on any kind of medical management, because you cannot explain this metrorrhagia that she's having or these short cycles based only on that 4 centimeter fibroid, and it is intramural. So therefore you need to sample, because she may be having an element of dysfunctional bleeding as well, AUB along with it. And hence you need to know what exactly is happening to her in addition to what you would do to correct the anemia. That would be my management in addition to the medical management that you're advising her.
I think I agree with Dr. Sonia. Yeah. I think in any women, you can't, unless you sample endometrium, you wouldn't know. So I think that's the point. We should, that's a good message.
Yeah.
Think of other things also.
OP biopsy, outpatient biopsy.
Just a
and she's anemic and symptomatic, and she's definitely worthwhile candidate for medical management.
Definitely.
So then what about, suppose if you want to plan the patient on medical therapy, what will be your first line of treatment, Dr. Asha? Will you go for GnRH analogs or SPRMs?
See, almost for 3 years, we did not have the sperms. No?
Yeah.
I think the last time I used is about 3 years back. So last 3 years, we have been only thinking of GnRH analog. It's only for a month that I put one patient on sperms just recently, a month back. Otherwise, for a long time, we have been thinking only of GnRH because it was not available. Now that it's available and the ban has been withdrawn, it's time for us all to discuss and see who is the right patient and which is the right condition. So now that Dr. Deepika is telling us a lot about this medication, I mean, it was a wonderful medication, but we all got worried about the liver problems. Now that the clouds are moving away, it is definitely worthwhile trying Ulipristal for this patient.
What about
but do a liver function test first.
Yes, that we will come later, Asha madam, that we will come in detail when we are discussing about sperms. What is the role of LNG-IUS in these patients? Because it's an intramural myoma, not distorting the cavity. GnRH analogs cannot be given for a longer period. If you want to control the menorrhagia, my view of looking at this patient is I will put her on 2 or 3 doses of GnRH, then insert LNG-IUS.
But somehow LNG-IUS for fibroid, I'm not really happy about.
Madam,
it does not give
cavity is
as long as there is effect of GnRH, it seems to work well. Once the effect of GnRH is over, then slowly, another 3 months also it will last, but later they start getting problems of menorrhagia and metrorrhagia due to fibroid.
Yeah, that is what I mean. The cavity is not distorted by the fibroid. One option is definitely LNG-IUS. Okay, let us move on to this thing. What are the current treatment options available? I think we have discussed the expectant management. Non-hormonal, of course, any patient when she comes to us first, the first drug of choice we will give is antifibrinolytics, and NSAIDs. If
Correct.
she responds to that, okay. If it is a small myoma, we can give her every month. Then comes the medical management. What are the other options of medical management?
So,
Yeah, the usual ones are the NSAIDs and tranexamic acid, which you can use temporarily.
and then, of course, all these hormone preparations that we have listed out over here, the combined OCPs and progestogens, that you see, all of them were basically being used not to decrease the size of the fibroid, but to counter the menorrhagia and metrorrhagia.
Symptoms alone.
Yeah, only for the symptoms.
Yeah, now I get one doubt that we have been talking a lot about progesterones in increasing the size of the fibroid. Do you think by giving more progesterones orally, can it be, increasing the size of the fibroid?
That's both ways, Asha. It decreases and increases. That is the problem. Particularly this molecule that we are going to be talking about. But of course, combined pills, we are not sure. We're not
The
sure.
Ulipristal Acetate, and do you think?
See, they are only symptomatic, Asha madam, that they can reduce the bleeding. That's all. Nothing is about the size of the myoma.
So now with the new thinking, do you think there can be a possibility of increasing the size of the fibroid?
Yeah, that is what we have
progesterones for a
discussed
long
already
time.
in the pathogenesis and how the role of progestins. We have explained that one thing is it can increase the growth, and other thing is by two ways. I have shown, put it in one slide earlier. And then,
Yes,
of course, the final management is only the surgical management. If the patient is desirous of once completed the family, if she wants to get rid of her uterus, I think hysterectomy will be the ideal one. Oh, then can you tell us what are the limitations of the currently available pharmacological management? Now here comes the OCPs and the progestins and LNGIOS. Okay, you can share, somebody can enumerate this.
I think, everything comes with a problem. Like everything, I mean, all is not good, all is not rosy. Like we have prescribed all of things for fibroids, like we have given oral contraceptive just to control the menorrhagia. But we know that because it has a estrogen also, it has a progesterone component also, so it may increase the size of myoma. And if the woman doesn't take it properly, or even if take properly, you can get breakthrough bleeding. And then there is an increased risk of thromboembolism comes along with the OC pills. And if you give the progestins alone, the bleeding pattern becomes inconsistent. And there is hypoestrogenic side effects to prolong a progesterone. The endometrium can, cause even the breakthrough bleeding, and women get signs of kind of like HRT, like menopausal symptoms. And then there can be ovarian follicular cyst along with the progestins only. And we have, I think, already discussed LNG IUCD, that there is a, it does affect the size of uterine fibroid, but there is an expulsion rate, and then again ovarian cyst and acne. So I think one has to balance, you have to balance the side effects with the benefits of anything you are prescribing to the patient. And I think it all depends on the symptoms and desire of the patient in terms of pregnancy. Suppose if she is in a reproductive age group and wants pregnancy, you will obviously not prescribe OC pills. So there are limitations. You have to choose medicine as per the patient's complaints and the patient's desire.
Yeah. Okay.
And though aromatase are supposed to cause hypoestrogenism, we are still not very confident, because we have not used much of aromatase inhibitors for.
And not much of aromatase inhibitors role in fibroids or in.
There are not many RCT sites, I think.
But we do quite a lot of aromatase inhibitors for adenomyosis. That's really good. But then regarding the GnRH agonist, we know the side effects of hot flashes and reduction in the BMD, etc. And danazol is one drug which we do not use nowadays. And symptomatic treatment has got no impact upon the fibroid size, and it has got only a limited data. So now coming to the current option, what are the newer options available? Sonia, madam? You have been keeping quiet for some time.
No. So now again, we've been talking about these selective progesterone receptor modulators, as sperm, as we are saying. These are supposed to be the most exciting molecule now, because they are supposed to be affecting not only the symptoms, they are not only controlling the symptoms, but also seem to be decreasing the size of the fibroid. So therefore, now in the medical management of fibroids, we seem to be having a breakthrough, because these are acting through the progesterone receptors. And therefore, basically, they are acting on all levels, as we shall see gradually, as you will be talking about it. They are, acting on all levels in the reproductive tract, and therefore seem to be a very promising option for these patients now.
Asha madam, see, the answer to your question is it acts like a progesterone in endometrium, reducing the bleeding, but it acts with an anti-progesterogenic activity within the fibroid.
My question was about the Ulipristal Acetate.
She didn't talk about this,
Yeah. So sperms are newer class of progesterone ligands displaying tissue selective agonist and antagonist and mixed activity on the target cells, and number of clinical trials have been established potential role of sperms in treatment of uterine fibroids. So what is the role of Ulipristol in fibroids, and what is the mechanism of action of UPA? Dr. Archana?
Dr. Ramani, I mean, this is as already said by both the panelists, that it is a very good molecule to reduce the size of fibroids. Basically, what it does, it down-regulates the expression of endogenous growth factor, that is VEGF, and that really helps in reducing the size. It also increases the expression of matrix metalloproteinases and decreases the expression of tissue inhibitor. So this can reduce the collagen deposition. That's how it reduces the size of the fibroid. Okay. So I mean, it is a very well studied molecule in terms of, very like how it is going to reduce the size of the fibroids. And it is approved by the European Union for pre-operative treatment of uterine fibroids since 2012. And we know that today Ulipristal Acetate is the most effective medication for conservative treatment of uterine fibroids. As Dr. Asha has mentioned before, we had used it 3 years before, and we have used it in really good number of patients, but because of the scare, it went and now it has come back again.
Yeah. So like how we have mentioned,
so it causes anovulation, but does not suppress the estrogen levels. No, it's very, very interesting.
That is the main difference between UPA and GnRH analogs.
Yeah, and the direct action on the fibroid, and it does not have much action on the normal myometrium. And it induces atrophy also in the endometrium most often. So it reduces the bleeding very fast within 5 to 6 days, which is very, very impressive compared to the GnRH, which takes about 3 to 4 weeks.
And the initial flare-up effect will be there, and the patient will have another bleed after 15 days of giving GnRH. So these are all some drawbacks. And mechanism of action, I think Dr. Archana has explained very well. And that is, it starts acting from hypothalamo, pituitary, and endometrial, and in the uterine tissue. And so on the pituitary gland, it maintains the mid-follicular estrogen level, so there is no hypoestrogenism, reduces LH and FSH secretion, inhibits ovulation, induces amenorrhea. And the action of fibroids is it blocks the progesterone receptors, inhibits cell proliferation, induces apoptosis. And upon the endometrium, it has got a short-term profound effects on endometrial proliferation, total suppression of uterine bleeding, and transforms the endometrium into atrophic endometrium. So what is now we can here discuss about the comparison of Ulipristol with GnRH analogs, which is ideal. I think we have answered part of this question already. Sonia, madam, can you update?
No, Dr. Basab is going to answer this one. He's just
Basab has come back.
I've come back.
Welcome, Basab. Welcome.
Thank you. Sorry for the delay. So GnRH analogs versus Ulipristal, I'm sure you have had already this discussion. GnRH has the problems of not being able to be given for a very long period of time, as the hypoestrogenic side effects. The problem of, as you said, the initial flare effect may be an issue, but at the same time, Ulipristal has been time tested, and before the liver disease scare and the liver effects scare, as you rightly put it, Dr. Ramani, it was the method of choice which we were using 3 to 4 years ago for any medical treatment of fibroid. But I think you will bring up some time that there are already questions in the box about Ulipristal and mifepristone as a comparison that would come later in your discussion, because one is off-label, one is label, one is very strong trials backing it, one has not very strong trials backing it, and I'm sure that discussion will come up a little later. But as we rightly said, that it was one of the most favorite molecules which we were using 3 years ago, and the recent coming back of it, let's see how the medical community will accept it, because now there is mifepristone and Ulipristal, both the medicines available. But I think there are a lot of more studies backing Ulipristal, which all of us will agree, and there is a very robust trials there, which would give us some scoring points there. But I understand you putting the physiology, you have already mentioned, Dr. Archana. I was following her when she was describing that. You can go on with the next question.
Yeah. So what is the advantage of Ulipristol over Lupride? I think that we have already discussed. Ulipristol has got a rapid documented onset of action and control of bleeding within 7 days compared to 21 days of Lupride, Ulipristal Acetate, and reduction in the uterine fibroid size lasts longer. Once when used, it is almost up to 45% at the end of 6 months, but whereas with the Luprolide, we get only 17%, and improves the hemoglobin levels. See, both Luprolide as well as Ulipristol has got a tendency to improve the hemoglobin levels of the patient, but the tolerability profile is much better with the Ulipristol, and pain control and quality of life is better with Ulipristol.
So yeah, about this reduction in fibroid size, Ramani, I was a little confused because most places it says it's about 53% with the GnRH analogs. And
Yeah,
about
GnRH on a long term, I think.
Luprolide.
Yeah, Luprolide is on a long term basis. Maybe the reduction in the size of the fibroids can be much more, or it is comparable to that of the Ulipristol. So, yeah, but anyway, the level of estradiol level in the periphery is kept at a good range, within a normal range, so that the patient will not have any vasomotor flashes or
no bone loss, perhaps.
Yeah, that is the most important one. So I think we can skip this pharmacokinetics. Only thing is it is being predominantly mediated by the CYP3A4, and the main route is through excretion is through feces and urine, and again through the liver metabolism. That is also very important. So that is why we get when the liver is already compromised, we are likely to have and land up with the liver failure.
Dr. Ramani, can I come in for a minute with the reduction in size of fibroids?
Yeah, of course.
Just one point which I wanted to mention, Dr. Asha mentioned it. To a patient, I think it may matter in a sonography if they've seen after 3 months a 1 centimeter reduction. For us, it doesn't matter because a 5 centimeter fibroid becoming 4 doesn't really have much of an impact. But for a patient, it may have a mental relief that yes, it's coming down or has come down, or your medicines have worked. For a fibroid just about pressing on the endometrium, it may make a difference. But the ultimate goal is like avoiding surgery and continue and having medicine having an impact. I think that's what a small reduction in size, 53%, 43%, ultimately clinically, I think it makes a little consequence, but amenorrhea is almost constant, and some reduction of size, like I think when we counsel the patient for when we're giving Ulipristal, I think that should not be a very big criteria that it'll reduce, it'll vanish, it'll reduce into half. If you make these promises and it doesn't turn out in the next sonography, then they'll be quite upset. I think the important thing is that you're giving them an alternative to a surgery, which is something which a lot of people will accept any day.
That your point is well taken, Dr. Basab. But the thing is, there is some marginal reduction in almost all the patients. But there are certain group of patients where the response is too good, and certain group of patients where you don't see any alteration in the size of following Ulipristol. That has to be individualized.
Absolutely.
So, Dr. Sonia, madam, what is the dosage of Ulipristal acetate you would like to use for your patients?
So it comes in two doses, 5 and 10. We generally give a capsule of 5 milligram, which is to be taken orally once a day. And the treatment is of 3 months. Now, the treatment course is very interesting. You know, you have to start the treatment and give it continuously for 3 months without a break, so that there is no period during that time. And then you give a break when the period happens. And then after that, the retreatment starts on from the first day of the next period. So there is a break of 10 days in between, and that is the time when the period is going to happen. And then after that, you start with the second course. So like that, you repeat 3 courses, and that is the time that you start studying or looking at it as to, like Dr. Basab said, you start looking at what is the size of the fibroid, and you start looking at the various
Madam,
that you are
shall I interrupt 1 minute? See, once when you stop the drug, the patient gets the first period.
Yes.
Then you wait till the second period.
One more cycle.
Yeah,
One more cycle.
yeah, 1 month of gap, almost 10 days plus 1 month of gap, that is 40 days between the courses.
Yeah.
So like that, how many courses you are going to give?
They have actually studied up to 6, but generally we are giving up to 4.
4 courses.
4 courses, 4 intermittent courses.
Yeah, Archana has been remaining quiet for some time. Archana, suppose if there is a failure to take the pill at a proper time, what will be your advice to the patient?
I mean, she's not going to get a withdrawal bleed immediately, but she can continue the dose, because you're not just going to say, okay, you are going to stop. It's very interesting, as Dr. Sonia has said, that you have to, give it for 12 weeks, maybe 13, basically 13 weeks. So I was really interested in knowing why, you always remember trimester wise, 12 weeks, 12 weeks, but here Ulipristal precisely is for 13 weeks.
Oh, I think it's because the trial was done that way. The trial was done that way.
Yeah.
Pardon?
The trial was done that way, Archana.
Yeah,
That's
3
what I'm
months
saying,
made
that
it 13
Pearl
weeks.
studies and all, it is 13 weeks. So, I mean, I just wanted to put this point, like you have to give it for 13 weeks. That is considered as one course. One course of
Being
medication.
an imaging person, I think each trimester that matters for you, Archana.
Yeah, that's right.
So now let me come to what are the effects of Ulipristal acetate on endometrium? Does it have,
Basically, yeah, I think basically it causes suppression, more of apoptosis. It goes into even atrophy. But sometimes there can be a cystic dilatation. The histological changes are described as progesterone receptor modulator associated endometrial changes. And even if it's a slight thickening sometimes, it should not be mistaken for endometrial hyperplasia. I have seen one of my patients going into almost a 2 centimeter thickness endometrium at the end of 13 weeks. But after menstruation, she promptly shed it, and later she had conceived.
So this is the picture that progesterone associated, that is the endometrial changes, scattered cystic glands with inactive epithelium. But whereas in contrast to the endometrial hyperplasia, where you can see the active glandular tissue, very crowded glands. So this we should not mistake it, and invariably we see this finding. And I have also seen in few of my patients where the endometrial thickness is beyond 2 centimeters. Now, what are the indications for Ulipristal acetate in management of fibroids?
I think
how?
Just one
So
point.
all fibroids respond, or whether you need to choose the type of fibroid for giving Ulipristal.
No, I think Dr. Ramani, you need to put on one message about thick endometrium. When do you shoot a biopsy, or when you don't do a biopsy?
Yeah, okay.
So what
see, like after that bleed, you redo ultrasound. Proceed, Basab. My way of looking at is, I wait for 1 or 2 cycles. That is, then after that you do a endometrial, you do a ultrasound, see whether the thickness has come down.
Fine.
If
because whenever it's menstruation, they seem to shed it off completely.
Yes. So that is one thing. So don't be bothered about the thickened endometrium. You wait and see after the menstruation.
Yeah, because you're going to wait for 1 month without giving the medication, and you can see the
it will automatically
thickness of the endometrium.
Yeah. So what are the indications? That is now my next question is, which sort of fibroids would you put the patient on UPA? Whether you want to put it for submucosal or subserosal or intramural myomas?
I think, if the fibroid is size more than 3 centimeters, you're not going to give it to the fibroids less than 3 centimeters, and intramural also, because submucous, I think you can really, like a hysteroscopic, all endoscopic person would like to do it with a hysteroscopy and remove it and done with it, rather than giving a patient a 13 weeks course of a long Ulipristal. So if something is easily accessible, do it, and then If it is like intramural more than 3 centimeters, my choice would be to give a UPA. And
Yeah.
how much and how long, I think Dr. Sonia has already explained, but there are questions in the chat box regarding the doses again.
Dosage.
So Dr. Ramani, we might repeat the
We will
doses
repeat it.
slide
We will
again.
repeat it.
Yeah.
Okay. So
When you
these are all,
when you say 4 courses, Dr. Ramani, that
Ah.
means it goes on for 1 year.
yeah.
I know many of them may not be really willing to wait for
Actually,
that much
though the
duration of
studies are
time.
given for 4 courses, in practice, do we use for 4 courses? No. I think most of us, I stop with 2. For infertile patients, I stop with 1 course.
Most often at the end of 5 to 6 months, they are really impatient.
Yeah. Yeah. What about you, Sonia madam?
I think
Would
one
you
point
like
is important.
When you're looking at an infertile patient, the
Ah.
problem is how she has to get pregnant very fast.
Yes.
Then that time she is not bothered. And as we will discuss the indications for giving this molecule, we will know that it is only like a stopgap arrangement for some time, till we can tide over that crisis, and maybe take her over for something which is required of her. So here, like Dr. Asha has said, we need to take her up for infertility management. I think suppose she's presenting with menorrhagia and what all, and we want to control that. And like Dr. Archana said, do a hysteroscopic removal and finish it off. Do all that and then take her up for her infertility treatment. So I think long management, waiting for a long time is going to make the patient run away or make the patient very impatient.
100%.
Can I come in?
100%.
Can I come in?
Yeah,
Dr.
yeah.
Ramani?
Yes,
Can I
yes,
come in?
ma'am.
Just
Yes,
2-3
Basab.
things. I think one important point is that it has to be a symptomatic myoma,
Absolutely.
not a size.
It has to be
So
a
that's very
symptomatic.
important. There are a lot of people who come with a fibroid and a Ulipristal prescription, but it's not symptomatic. So that's not indicated.
No,
So
it's not
first it has to
indicated.
be symptomatic. That's number
Yes,
one. Very
yes.
important point. If it's not symptomatic, you don't need medical treatment. That's number one. Number two, so the size doesn't matter. If it's a 2 centimeter and then it's troubling, then
Don't
it
bother.
has to be there. For infertility, I think that's the last indication you'll be giving it.
Yes,
Usually
yes,
you give it to rise up the hemoglobin, postpone a surgery, make time for surgery, perimenopausal to tide over menopause. Those would be the first lines of treatment. What is the stopgap alternative in a short period of time?
Yeah, I have one.
Your Basab, your voice is winning. Your voice is not
The voice
heard.
is gone.
Voice is gone, Basab.
I think
Okay.
he's traveling.
Yeah, I
He's on-
think yeah,
he's
he's
on
getting.
move, so
Yeah, just,
connection
I have
might
one
be-
question here for the panelists and for the moderator. There's one young woman with me now. She was 140 kgs, and after bariatric surgery, she has come down to 108 kg. And she has a type 3 fibroid, 4.9 into 3.8 centimeter. And her AMH is pretty good. She underwent egg collection, and for her, 6 embryos have been vitrified last month. So what should we do about this grade 3 myoma, which is, she has no other symptoms of menorrhagia or pain. 4.9 into 3.8 centimeter.
My view of
Intramural.
looking at it is, maybe I will give her 1 course of Yuliprist, then go ahead with, of course, histoscopy, pre-transfer histoscopy is a must. Just want to rule out any other small, tiny polyps or tiny myomas that are present inside the cavity. That has to be ruled out. Maybe give her a course of Yuliprist, then transfer. Because I have had...
Yeah, this is exactly what I've done. I have started her on Ulipristal about 3 weeks back. Her father is a microbiologist. Immediately he comes running. We took a consent for liver problem, etc. But then he was very much worried. He said, my daughter has undergone a bariatric surgery. She might be more sensitive than others. Dr. Asha, please be careful. In such cases, you really feel, should you be fighting with Ulipristal, or should we go in for a GnRH analog, which also can give you enough, because it's not, it is type 3 typically. It is not really getting into the cavity. And with 3D ultrasound, her endometrium is beautiful. And this young girl who has undergone already a bariatric surgery, and she's still obese, she's 108 kg. So I wouldn't really like to go jump in and do a myomectomy. So we have put her on Ulipristal. I'm going to do an ultrasound at the end of 4 weeks. If I'm not happy, or patient is unhappy about Ulipristal, or father is very much worried, then maybe I'll be forced to shift her over to GnRH analog.
Yeah. So the main 2 indication situations in which it is particularly useful is infertile patients, and then a perimenopausal woman who is not willing to undergo surgery. but she can, if she is treated with the Ulipristal Acetate, and during the, over a course of time, the fibroids can shrink and she may become asymptomatic.
Ramani, sorry, in the meanwhile, there was a comment here in the chat box. We said 5 centimeter fibroid in obese person, laparoscopic surgery is the answer. I beg to differ, Dr. Priya. Obese person, 5 centimeter myoma, I think it's worthwhile giving them Ulipristal and wait, because every surgery has morbidity and mortality.
Yeah, there is no question of, even I would
obesity.
I would like to defer surgery for this obese patient.
Yeah, definitely we would like to wait rather than go for surgery.
Yeah, yeah.
But tell me something, excuse me, tell me something, this fibroid is not indenting the endometrium, it is nowhere close by. It is an intramural fibroid of 4 centimeters maximum, isn't it, Asha?
Yes,
why do we 4.6 centimeters?
5 centimeters. Why do we have to reduce it? There are so many patients who conceive with a 5 centimeter submucous.
Yeah, I'm rather concerned about the possibility of a miscarriage or preterm labor. So there is no harm in giving her a medical management.
It is
to reduce the size. If it can move a little away from the endometrium and vascularity reduces, I'll be very, very happy. The anti-angiogenic property of Ulipristal, I think, is very impressive.
Yeah, and I was thinking like Dr. Sonia along the line that why, I mean, this is debatable. Why would you not do just embryo transfer without doing the myofibroid, which is sitting away from your endometrium?
No, this would have been my thinking if I had to do a laparoscopic surgery. But if I can do reduce the angiogenesis and reduce the size of the myoma, if the myoma can move away from endometrium, it's aborting the endometrium. It's type 3. I would be very happy, and the concern is about possibilities of preterm delivery. I have seen the fibroids getting bigger during pregnancy, just like adenomyosis. You suppress them well, the chance of preterm labor are remote.
But then we have also
otherwise they can be very aggressive, and chance of preterm labor are more with adenomyosis. So is the fibroid.
Again, although fibroid is the commonest tumor, it is also the most debatable tumor. I have seen patients who just don't go into anything, they just deliver.
But intramural fibroid of 5 centimeter, there is a high chance of preterm labor.
Not at all.
Madam, one more thing is, the fibroids, they tend to increase in size during pregnancy only in the early trimester. Beyond that, sometimes it gets flattened and doesn't cause any problem. So, per se, fibroid causing preterm labor is, it is quite debatable.
Yeah, you should look into the RCTs, perhaps.
My worry here, Dr. Asha, how much experience of you having Ulipristol in a woman who has undergone surgery for obesity? Because the enzymes are very different in women who have gone through weight reduction surgery. So a little bit of pinch of this thing you have to see that, because there all enzymes are different and how she's going to be.
Yeah, unless you try, you never know, Dr. Archana.
Archana, I think we are deviating.
Yes.
So let us come to the track.
Okay, let's get on with the Ulipristol only.
Yes.
I think we always try to deviate and just we want to resolve that one patient complete rather than looking at the broader thing. Okay, go.
Okay. So Ulipristol can be used in this way in different types, like with women with class 0, 1 and 2 symptomatic fibroids greater than 2 centimeters distorting the cavity and wishing to preserve their fertility. With myoma reduction, UPA may make the hysteroscopic myomectomy procedure easier and reduce the number of 2 steps procedure. But I am a bit reluctant to do this because myomas, after giving Ulipristol, they become they become apoptotic and they become necrotic, and they are not, I find it difficult even after GnRH usage to do a hysteroscopic resection. So probably I may not accept this, but it is left to the discretion of other consultant. And UPA could also become an alternative to hysteroscopic myomectomy if a good clinical response is obtained and if uterine cavity is resorted. This I will agree. Sometimes what I see is small, tiny myomas, myriads of myomas when they are there in the endometrial cavity. You cannot be going and doing a resection of all these myomas, which will distort the endometrium and destruct it. So maybe in such situation, and with the women with a class of 5 or 6 large myomas could be treated with UPA preoperatively to permit the laparoscopic myomectomy instead of laparotomy. So
A
this
small
is,
difference of opinion here, Ramani. Just one
Pardon?
sentence.
Hmm.
Small difference of opinion. For laparoscopic myomectomy, we would not use GnRH in the law.
Yeah, that's
But
the
for
same thing
hysteroscopic
I'm telling.
myomectomy, GnRH or Ulipristal, both are all right.
Yes.
No, I
Human
find
becomes
it
softer,
difficult
but
to
vascularity
research
is
it.
less. The chances of pulmonary edema will be much less. It's very, very important.
I find it difficult to remove it because it becomes very soft. Resection becomes difficult. Okay.
It's like scooping out ice cream.
You have to leave the capsule and go inside.
Okay. So management of myoma, this is an algorithm that was given in the human reproduction update. So it basically depends upon type 2 to type 5, whether the patient desires pregnancy or not desirous of pregnancy. Desires pregnancy, see here again the long-term intermittent SPRM therapy for 2 courses. If the patient has got a very good response, she can go and try for a natural conception. If she has a good response with the reduction in the volume of up to 50% with the control of bleeding, again, she can try a natural conception. And if the cavity remains distorted or if the myoma remains larger, maybe myomectomy can be undergone, can be planned, or if there is no response, then myomectomy should be done. Again, if there is no desire for pregnancy with intermittent 3 or 4 courses of SPRM therapy, good response, stop and follow up, and then insufficient response, then go for myomectomy. So there is again in this, I think we have discussed already, in perimenopausal women who are not willing or unfit for surgery, Ulipristal acetate can be used so that the fibroids will shrink and almost they will reach in the nearing perimenopause, they will reach a state of menopause where the patient will become very comfortable. So again, this is for a patient with a perimenopausal period. How do you grade? This is what we have already described. With a good response, stop treatment until the recurrence occurs. Or if there is no response, maybe hysterectomy or myomectomy or uterine artery embolization. I think in our setup, the preferable mode will be hysterectomy in a perimenopausal woman. So now, anybody can share what are the contraindications before giving Ulipristal. You can sort out certain things, 1, 2, 3, 4, that we do not want to give this particular patient Ulipristal. What are the points?
Yeah, number 1, you have to rule out possibilities of any pre-malignant condition. Like Sonia said earlier, it's very, very important to do a biopsy and see that there is no malignancy of the cervix, uterus, or breast also. Number 2 will be rule out pregnancy. Number 3 is rule out liver diseases, liver problems. So it's very, very important to do the liver function test and explain to the patient and even take their consent that occasional problem, 1 in 1 lakh has been reported, or rather 6 per 1 lakh, I think. So even if it is 6 fatal cases, I mean, who suffered liver problem, it's very important to tell the patient and take a consent also.
Okay. So then again, with women with severe asthma who are poorly controlled with oral glucocorticoids, it's not recommended. And then breastfeeding women. So now let us come to the clinical studies. What are the Pearl studies that are available? We see that these Pearl studies are the most important studies for the use of Ulipristal acetate because they have been done from Pearl 1 to Pearl 4 studies in phased manner. Now, what was the drug, I mean, Ulipristal, how it was used in Pearl 1, Pearl 2, Pearl 3, and Pearl 4? Can anybody enumerate?
Pearl 1 is 5 milligram per day, 5-10 milligram for 13 weeks, and compared to the placebo.
Yeah.
And Pearl 2 is 5-10 milligram per day, again, compared to GnRH analog, which was given as monthly dose of 3.7, 3 doses.
Yes. Then
Pearl 3, of course, 4 courses were given over 3 months.
And again, here also they had used Pearl 3, 5 milligram, 1 division, and 10 milligram also.
Yes, there was also there was also an extended study of 8 courses.
Yes.
Pearl 3 and 4 had 4 courses and 8 courses.
Yeah. Pearl 4 is?
Pearl 4 is interesting because they compared the action of 5 milligram versus 10 milligram. Of
what was the result? Inference? They found both were found to be the same. No statistical significance.
In fact, I studied in depth because I was worried about this obese girl, the 110 kilos that she required higher dose. Then I said, no, take only 5 milligram.
5 milligram is sufficient. So the primary objective was in Pearl study. They wanted to compare with the placebo, only the reduction in the fibroid volume. Pearl 2, they compared with leuprolide. And Pearl 3 was a long-term usage of 10 milligram. And with the Pearl 4, efficacy and safety of long-term usage. So the conclusions, I think we have, bleeding was controlled in 91% of the cases within 13 weeks. Amenorrhea occurred within 6 days. That was the major advantage over the leuprolide. And reduction in the fibroid volume to an extent of 20% at 13 weeks and 54% at the end of course 3. And multiple fibroids over a size of 3 centimeters and 12 and less than 12 centimeters, they had studied the effect. And there was definite improvement in the quality of life, pain, anxiety, depression, and documented clinical use was there for a more than a period of 18 months. And reduction was size of the fibroid was maintained. But my thing is how it is going to help in such huge fibroids of beyond 10 centimeters. What is going to be the reduction in the size? See, maybe I can accept for a fibroid of 5 to 6 centimeters. Can anybody share your experience with when using Ulipristol for a fibroid of more than 10 centimeters?
Yeah, I had this African lady who was 34 years, and I have never seen an African without fibroid. This lady was married for about 5 years. She had come on some business. She was staying in this place called Tirupur, which is next to Coimbatore. And she had a 32 to 34 week size uterus, multiple fibroids, and very keen on any procedure which will make her pregnant. I said, and we gave her Ulipristal, because there's a time that now all of you want to try Ulipristal. And she had taken about 2 courses. There's almost 6 months. At the end of it, she was getting a little nausea, and the bilirubin had gone up to 2 milligram. So we stopped the Ulipristal, and we said, again, come for a periodic check of the bilirubin. And within a month, she was pregnant spontaneously. She conceived, and I was scared. So at the time of 8 weeks, when a heartbeat appeared, I shifted her to one of the tertiary care hospitals, gave a letter and said, my dear friend so-and-so, kindly take care of this girl. They were taking good care of her, and they did a circulage at 16 weeks, I believe. And at 20 weeks, she came with heavy bleeding, and she lost the pregnancy. So this is how she was not operated, because I was even worried, the lady of being a foreigner, getting her operated in India with so many fibroids. She conceived but lost the pregnancy at about 20 weeks. But she conceived post Ulipristal.
So Sonia madam, what is your experience? How to which size of myomas have you used it?
I have not used it at this. I have not used it in any of these big fibroids at all.
Yeah, even me. Up to 5 centimeters, maybe I am happy using it. And probably with the 10 centimeters, I don't know how far the size of the myoma will come down. I think again,
even I have not used it in more than 5 centimeters. Because if it's a larger is the fibroid, the size reduction will take time, and how long you can give the treatment.
So maybe such patients, they should be shifted to surgical management.
Yes.
So the limitation, we can say up to 5, maximum 6 centimeters. So again, this Ulipristol versus GnRH analogs, we have discussed enough. And again, there are a lot of drug interactions with herbal products and barbiturates, carbamazepine, greaseprevir, phenytoin, rifampicin, and etc. So because it is being stabilized by CYP3A4 inhibitor, so that we have to be very careful. So I think now this is how they give the Ulipristol course. We have discussed it. Start on day 1 of the menstrual cycle. And now the current thing is you can start on any day of the menstrual cycle. Okay, then give for 5 milligram, continue for. So there are certain prerequisites. Prior to starting Ulipristol, how do you counsel the patient, and what are the basic investigations would you like to do?
So that
I think we have to do liver function. Yeah, Dr. Sonia, go on.
No, it's I think we have already discussed it when we were talking about contraindications, no?
Yes.
These are the things that we have to be careful about. We have to rule out, like Asha said, malignancy, liver disease, and all that. So we have to counsel the patient very carefully in the beginning also about all these things, because anytime during the course of this medication, if the patient comes with liver toxicity, we have to stop the drug, no? So
Yes.
therefore, that has to be told to the patient that, okay, we are giving it to you, but we may have to stop it in between. That counseling has to be done. And of course, along with that, we have to keep on guarding against any of these things coming up. That is important all through the thing. I think there is a chart which you have, Dr. Ramani, which shows when to do the liver function test.
Yeah. I will show
I
that,
think we
madam.
should show that. Very
Yes,
very
I will.
important.
I will show
Talking about heavy bleeding and Ulipristal, I think the way it can control bleeding rapidly is very impressive.
Yes.
Because once
That
we
is
had
the
this
main
lady with
advantage.
three
Amazing.
submucous fibroids,
Amazing.
young girl, married 1.5 years. She came with menorrhagia, heavy bleeding and hemoglobin of 6 grams.
Yeah.
So we had put her on 1 dose of GnRH, but then we know that GnRH takes time to act. So I started on Ulipristal and she had 3 myomas, 3 centimeter, 3.5 and 1.5. At the end of 3 months, this tiny one disappeared. The 1.5 centimeter had absorbed. We did a hysteroscopy and removed 1 myoma first, excision. We didn't want to have the 2 fibroids removed and get because very rarely I have seen 3 submucous fibroid. So we removed 1 fibroid. Then after 2 months, we did the second myoma resection by hysteroscopy. And 2 months after that, she has conceived naturally without any other therapy. She was a young girl, young slim girl, and she has had a term pregnancy. And now after 3 years, she's coming back seeking a second pregnancy.
Okay, so this slide shows what is the decrease in the fibroid size with your Ulipristal acetate. Say after the first course, maybe to 40% reduction, and it goes up to 60 to 65%. I don't know, but though the study says practically, do we see such drastic reduction in the size of the fibroid? It's really questionable. Okay, but definitely the quality of life, the improvement of menorrhagia, everything is better with few courses of Ulipristal acetate. So this was by the European Commission decision earlier. They stopped using, see, Ulipristal was into the way, and again DCGA stopped this Ulipristal by 2018. Once they gave approval, in 2018, sorry, they gave the approval for the use of Ulipristal acetate in fibroid, but later soon by 2000, I think in 20 they had
2020 it was withdrawn.
20 yes. They have withdrawn because of the liver safety issues, I think, about which we have discussed, and Dr. Asha had rightly pointed out some 6 out of some lakh patients, they tend to have this liver dysfunction, and hepatic transplantation has been done in few of the patients. So that was withdrawn. But then, so now how to revamp that? Reuse of this Ulipristal, how we should do. So first thing is, you should, underlying liver disorders patient, you should not do it. And liver function test has to be done with a good amount of counseling. Then the next question is, how often you are going to repeat the liver function test?
Yes.
Yeah, and first of all, I think we should convince ourselves that surgery also has morbidity and mortality. You can have post-operative additions, post-operative, recently we had a case of surgery went off very well, but then 3rd day she started having nausea, vomiting, and there was a bowel, which was just stuck lightly to that area of surgery. And after 2 more days, we had to go and release that addition. Girl has done well. So remember that every surgery carries morbidity and maybe remote chance of mortality. And morbidity could be, additions are much higher than this 1 in 1 lakh liver problems. But when it happens to that particular patient, it is 100% fatal. So kindly counsel everybody that there can be liver problem. And now we are recommending the LFT every 2 weeks.
That is what there is.
Every 2 weeks.
Yeah, earlier it was said at the start of the treatment, you do an LFT, then after completing 4 weeks, you repeat it. But now the DCGA guidelines are very clear that it should be done. So this was the LFT monitoring should be done prior to starting monthly. But now again, this was in the ESMIA trial. But now we know the current DCGA, they have given approval in 13th December 2021 with the following guidelines. I'll put it. The restricted indications for 5 milligram. We are supposed to use only 5 milligram, not beyond that.
Yeah, and it's impressive that November 2020 it was withdrawn, and by December 2021 we have obtained the permission again.
Yes, yes. So the pharma company has worked so much. They want to bring back the Ulipristol, which has got definite role in management of fibroids. So this is definitely, what are the, Archana, what do you think, what are the indications for using Ulipristal acetate in the current scenario?
I think the indications are in women who are symptomatic, as we have already said, that those who have menorrhagia, and number two, they're like, as we have discussed already, when there is infertility, is like, not this patient is not in a rush for having the baby. So that's the one. And the second thing is, if patient has condition which where you would not like to operate yourself, like she has comorbidities along with the fibroid, and there in the cases you would say, well, let's do the medical management and not go for surgical thing, and where it really has a great role.
So I think we'll have to respect the guidelines of the DCGI, and according to them, it is to be used only in a premenopausal woman who is not fit for surgery, in that. But of course, with the caveat that she has to have a fit liver also.
The way we have in India today, a lot of diabetics, obese people.
Diabetes,
non-alcoholic fatty liver is very common nowadays.
Yeah. So is it safe to use it in them?
Yeah. So they will have to be careful, and we cannot sort of use it in all the patients, especially now. But again, Dr. Ramani, I think with the gradual use of the drug, as we get more used to it, we'll have more confidence in the usage, and probably the indications might improve. But as of now, we'll have to be very careful, because we are gradually going to return it back to, usage. So we'll have to be very careful in which patients we are going to use it. I think
that's why it is very important to have this kind of discussions where we can share our experiences, and even the like the companies who have run the extensive research can bring their inputs, and they can enlighten us, and we can enlighten the delegates regarding its uses. So I think it's very important, and I'm really enjoying this discussion.
I think in the Indian context, Dr. Sonia, if there is a 3 centimeter or 2.5 centimeter submucous fibroid in a perimenopausal woman, it's better to go and take it out by hysteroscopy rather than give 4 courses of it.
Of course.
So submucous myomas, always the first line of treatment should be hysteroscopic myomectomy, whatever be the age group. Because even in a
perimenopause, when it is not fit for surgery, it's written that when it is not fit for surgery.
Sometimes the patient themselves will say, Doctor Sahab, hame operation nahi chahiye, hame dawai do. But you should convince her that perhaps simple surgery is better than long-term medication.
Yeah, recently I would like to share my experience. One patient with severe pulmonary stenosis, not taking a proper treatment. She came with severe menorrhagia, and I found out a small fibroid, submucous myoma, that was jetting out. So the cardiology clearance was not obtained, but then I thought, because it was only a jetting myoma, I can just go and clip it off. But when I did it, then I just wanted, because the os was open, I put in a scope and find out, to my surprise, I found out another 2 centimeters submucous myoma sitting inside. Somehow I was bold enough, my anesthetist was bold enough to manage the patient, and I was able to go ahead with the hysteroscopic myomectomy, and that was a single time procedure for her. Now let us look into some of the guidelines. This was a guideline by RCOG in 2016 for heavy menstrual bleeding, where they say that heavy menstrual bleeding due to fibroids of 3 centimeters or more in diameter when the hemoglobin is low, you can go ahead with Ulipristal acetate 5 milligram for up to 4 courses. And again, so this is, and another thing is, either we can offer, or you can consider women with heavy menstrual bleeding and fibroids of 3 centimeter or more, and a hemoglobin level of more than 102 grams per liter. So they are offering it, that they can either offer or they can consider. So then what about the NICE guidelines that was released in 2018, that also is in favor of Ulipristal acetate, but we have to be very careful with the serious liver injury associated with that. So we have to monitor the patient. So that if there is no underlying liver injury or surgery or uterine artery embolization is unsuitable, then Ulipristol will be the drug of choice for perimenopausal women with HMG. Fibroids are 3 centimeter or more, particularly when the hemoglobin level is low. I think in the absence of liver dysfunction, the disorder, this patient can be offered. Then there was again another guideline by the Italian Society where they were also in favor of treatment of symptomatic uterine fibroids with COCs, LNG-IUS, and but they are now moving on slowly to the Ulipristal Acetate. So now
what is the cost of Ulipristal Acetate, by the
way?
way?
That I am coming to the rare end.
130 rupees per tablet.
Yeah. How does it have any impact on the future pregnancy rate, abortion rate, or take-home baby rate?
Nothing.
No, nothing. No. I don't think it has any role because madam.
Yeah. So there are again lot of literature evidences to show that there are good pregnancy outcomes. This was an article published in 2018. 7 studies included 6 case reports, 1 retrospective series, and 24 post of UPA pregnancies, where they found out that it can permit consumption and a favorable pregnancy outcome. Again, there was a single case presentation of Ulipristal acetate prior to ART in fibroids, and the outcome is it has got a triple effect. It ensures prompt symptom relief, reduces the size of the myoma, and it improves the morphology of the uterus, thereby improving the IVF outcome. So again, this was another study from Spain where successful pregnancies has been reported after Ulipristal acetate. One more from, I think, I don't know from which country, again, after an ICSI procedure, successful outcome. Again, there are few more case reports. So I would request the learned panelists to share if you have come across a single case of ART, pre-ART, where you have used Ulipristal acetate and the outcome of the pregnancy.
Yes, again, in a very, not in a large myoma. I started to use it when this was, when it was allowed. That was early, not now, earlier. Now when it is
2018 to 2020, probably.
Somewhere in 2019, I used it. And then the idea was to reduce, just as Archana was saying, the myoma was more than abutting the endometrium, more than that. And it was on the posterior wall. It was an intramural, but more than 50%. So in order to reduce the size, we used it. It was only given for 3 months. I did not use it for more than that. There was I don't remember how much was the reduction in size, but then we did an ART. I was careful to put the embryo not at the site of the myoma, a little lower than that, and trying to avoid that site where it was. And then we were successful in getting a pregnancy in that patient. So I do remember using it slightly, but not to a large extent.
Archana, because in the world literature also, we do get only case reports.
Yes.
Not series, big series has not been reported. What about Asha, madam? Have you come across post ART? I mean, with the prior use of EP?
No, because I think 2 of my patients conceived spontaneously.
Yeah.
We did not have to go for ART.
No, I have not come across because, this has come recently into this thing, again. So maybe in future we are looking into such kind of scenarios where they had a prior treatment and then IVF and then results. So I think this is still, it will take some time for us to collect the data on this aspect.
Yeah,
I have this obese girl with
experience of one patient who had 18 myomas and she was operated by Dr. Kurian Joseph. He has done an open myomectomy because it was 24 week size. And after 1 year, she came to me because she was a resident of my city with again multiple intramural myomas. Small myomas, and the uterus was around 8 to 10 centimeters, 8 to 10 weeks of pregnant uterus. So then she was very keen on conception. I did a histoscopy, the cavity was normal. So I gave her UPA for 1 course of UPA.
1 course.
Then, prior to that, I had picked up the embryo, and then embryo freezing was, oocytes embryo freezing was done, gave UPA, then I transferred. She became pregnant. But on doing an LSES, I found that was another big myoma sitting in the uterine cavity. So this time, along with the baby, I removed that uterine myoma also. And of course, I couldn't remove the uterus. Exteriorization of the uterus was not possible because the entire uterus was plastered because of the previous myomectomy. I had to go through an extraperitoneal C-section. So then I told that girl, come and have a LNG-IUS at least for a for your symptoms to become better and for contraception. She never turned out, but instead she turned out after a year's time with another spontaneous
pregnancy.
Spontaneous conception. This time she had another large myoma that was sitting in the lower uterine segment. Then I had to remove the myomectomy, go ahead with the myomectomy, then remove the baby. So that was the story of my only one patient who had conceived with UPA, and now 2 more of my patients were on UPA. After this release of this ban, I have put them on Ulipristol and they are waiting for ART. Now, last question is...
My patient was also on some homeopathic medicine along with the UPA. So I don't know
whether it is homeopathy or allopathy.
It was UPA, but that is what limited experience.
Okay. Cost of the therapy, Dr. Asha Madam was asking. I think it is
130. One of the brands is 130 rupees a tablet.
It is 11,000 for one course of treatment. 11,000 precisely.
140 to 50 rupees per tablet.
Yeah, multiplied by 90 days. So that's how you calculate. So I mean, it is good to inform the patient in advance.
I think it's equal to the cost of one GnRH analog of 11.25.
Yes,
it is equivalent, but yes, patient should know the total cost of the treatment rather than just the tablet for 1 month or so. So that the whole course would cost that much. And we can ask Jagsonpal to reduce so that, we can really offer it to many women.
I'm sure they will. I'm sure they will.
So to summarize, UPA is a new, effective, well-tolerated option for pre-operative treatment of moderate and severe symptoms of fibroids, intermittent treatment of moderate to severe symptoms of uterine fibroids in adult women of reproductive age, correction of anemia. It is fast-acting, then had better tolerability profile when compared to leuprolide. It results in significant reduction in the size of fibroids, which lasts at least for 6 at the end of the treatment, and keeps the estradiol levels and follicular phase range. Thereby, there is no incidence of hot flashes and there is no impact on the bone marrow turnover. Allows for planning treatment strategy tailored to meet an individualized patient needs. UPA may be a good option for women with fibroid uterus who wish to avoid surgery and there is or when they want to postpone the surgery. So perimenopausal women who are not willing to undergo surgery despite the failure of other medical treatment.
I think it was a very good discussion. There were few questions in the chat box with the mifepristone and doses and how much to give. I think, Ramani, you have to have one more seminar with Ulipristol versus other medication. I think we are not finished today. We have just completed one aspect of Ulipristol because there are questions on pregnancy with fibroids and other things. So I think it's obviously contraindicated at the moment in the pregnancy and breastfeeding. Ulipristol is not approved. So, but still, I mean, we'll see how the future evolves. So I think
a few of the questions I think we can take up. How was Ulipristol to be given and how long, that we have discussed. How effective in adenomyosis? There is no role for its action in adenomyosis. Dr. Manindra Ahuja has asked, does mapping of myoma help in deciding the treatment? In fact, a simple ultrasound will be sufficient. And if progesterone is the culprit for the growth of the fibroid, then why is LNG-IUS advocated? LNG-IUS, by the local action upon the endometrium, it causes the atrophy, thereby reduces the bleeding. So it has got only local action. If a patient around 40 years with a 5 centimeter intramural myoma with simple hyperplasia without atypia, can Ulipristol be used in such cases? Intramural, not involving the endometrium, I think it has to be managed with like any other simple hyperplasia, like you can put the patient on OCP or progestin for a few months, and then we can go for the review. Some of the other questions, any birth defects, I don't think we are using it during pregnancy, and we have given enough of evidence to say that pregnancy is quite safe. And I think some of the other questions, any role for OCP, we have described, we have discussed that only for control of symptoms. Mirena only in small polyps. I think purposefully we have not discussed something about mifepristone today. Mifepristone 25 milligram is an alternate to Ulipristol. It has got definitely it has got a good control of bleeding and growth of but I think mifepristone in use of fibroid, it's only off-label.
Not only that, it has got no effect on the size and volume. If you're also thinking of reducing that, it will not reduce the size. But of course, symptomatology, yes, it will.
Yes, maybe. Then if patients, will patient conceive during Ulipristol? No. Can we give simultaneous ovulation induction? No. Once when you stop the Ulipristol only, you can go for ovulation induction. I think side effects, we have informed, I mean, most of the patients, they complain of mild nausea and vomiting. That's all. Otherwise, there is no gross side effects except that the liver injury that we have to monitor, and cost we have discussed. In any situation, is there a role of combining Ulipristol with GnRH analogs? I don't think we need to combine. No.
I think then you would not know whether which drug is active.
Which is active. Yeah. Is there a logic of giving Ulipristol for 1 month as mentioned by our esteemed panelists? No, we have not discussed anything about 1 month. Probably one course of Ulipristol we would have discussed.
Yeah, that's what we have discussed. Yeah.
What to do with the subseral fibroid? If they are asymptomatic, just observation will be sufficient.
I think you have covered most of the questions.
It was a very, very interesting
panel.
Very nice. Very
panel and discussion.
Thank you, Dr. Ramani. Thank you.
Thank you. Thank you all.
I had the privilege of having all experts from Northeast, Southwest today with me. And I think I also really enjoyed moderating this panel with all the experts around me. And I should thank Dr. Deepika Chopra for giving me this opportunity.
Thank you,
Deepika.
Thank you, Ramani. Thank you, Deepika and Jagsonpal.
Thank you
for a wonderful session.
Thank you so much. Yes,
it was educative for all of us.
We all studied. We all studied.
And along with me, ma'am, we also have our marketing team here. So I'll just ask one of them, Mr. Vijay Singh. He's our brand manager, Yuliprist, if he would want to say a few words.
Yeah. Thank you, Dr. Deepika. And first of all, good evening to all respected doctors. I'm Vijay Singh, the brand manager of Yuliprist. Bring greetings from NAARI division of Jagsonpal. We thank you for this opportunity to connect with you all today through this webinar, and are proud to present Yuliprist 5 mg tablet for long-term management of fibroids. Doctor choose Yuliprist to save her uterus, as we at Jagsonpal are fully compliant with the latest guidelines and recommendations given by CDSCO and the DCGI about the liver safety, and suggest the monitoring of LFT during treatment. And doctors, yes, choose Yuliprist for the management of uterine fibroids when the surgical procedure and embolization not appropriate, not work, and the patient not willing for the surgery. So doctors, please prescribe Yuliprist, as the doses already we have discussed in detail. And I personally thank you to all the participants for attending. And yes, the Yuliprist is safe in long-term intermittent therapy up to 8 treatment courses. So thank you very much, doctors.
Long-term courses was described in Pearl 3 extension study. I think Dr. Asha had mentioned about it. So thanks to everyone, the organizers and the panelists and the participants. Thank you.
One more thing I'd like to share, ma'am. As ma'am are saying, we need to decrease the price of this Yuliprist. Ma'am, we are also offering to the patient the subsidized rate if the patient direct come to us through your referral, ma'am. So we are already providing this, ma'am.
Acha, okay, that is good.
Yeah, ma'am. Thank you, ma'am.
Our marketing
thank you.
manager, Mr. Saurabh Sharma, would also like to just thank everybody, ma'am.
Yeah.
Hello, Dr. Ramani. Hello, Dr. Sonia. Hello,
Hello.
everyone. My name is Saurabh, and I am looking after marketing of NAARI division. Thank you very much for just be a part of this beautiful session. I also enjoyed and learned a lot. We definitely percolate down in different ways and meaning by different literatures and conferences. As a member of Jagsonpal family, Doctor, I feel very proud that we are continuously working in the direction to provide you quality products in our basket for all phases of woman life. Once again, requesting your support to the relaunched brand Yuliprist to save her uterus. Please join us again this Saturday for a webinar on cesarean section. To register now, please note down the webinar ID displayed. Thank you very much. Thank you very much all.